Ontogeny drives dental development. Pathophysiology reveals decay. Therapeutics offer advanced restoration. Forensics provide positive identification. Genomics determine dental morphology.
Human teeth are classified by their specific morphology. Incisors, canines, premolars, and molars serve variations reveal population history, such as the shovel-shaped incisors in some ancestries.
Human dentition is a highly specialized system. We transition from 20 deciduous teeth to 32 permanent teeth. This system is heterodont, with 4 distinct categories. They are arranged in upper and lower arches.
Positioned front and center, incisors are optimized for cutting. They feature sharp, chisel-like edges. Adjacent to these, canines are engineered to rip and tear. Their long roots withstand massive forces.
Premolars, or bicuspids, are 8 teeth posterior to the canines. Their dual cusps assist in tearing and crushing. Molars are the most posterior and widest teeth. They grind food into a bolus suitable for swallowing.
In 66 AD, Nero's mistress. In 1066, William the Malaline teeth on wax. Today, systems like Asudus classify these traits. This establishes dental profiling. Shovel-shaped incisors feature a pronounced roll on the lingual surface. Torus palatinus is a bony exostosis. It serves as a supplementary marker for profiling.
Carabelli's cusp is an accessory cusp. The hypocone exhibits sexual dimorphism. Males generally display more developed hypocones. This variation is statistically significant. Accessory cusps like the protostylid and hypoconulid vary by sex. The distal trigonid crest occurs only in females. Primary teeth begin their formation between the 6th and 8th weeks. The first sign is the detail of the dental lamina. At week 8, the bud stage begins. Cells condense around the epithelial bud. By week 9, unequal growth creates the cap stage. This forms the enamel organ and dental papilla.
During the bell stage, cells differentiate. Odontoblasts secrete predentin, triggering enamel formation. Mineralization is followed by root formation and eruption. Development begins with initial calcification. The crown completes at 4 months. Mandibular eruption follows 5 to 9 months. Maxillary eruption occurs slightly later. Root complete finishes by 2 years.
Let's review the development of the deciduous canine. Calcification begins at 4 months prenatal. The crown is fully complete by 9 months. It erupts between 19 and 20 months. Root completion occurs by 3 years. Let's review the development of the deciduous first molar. Calcification begins at 4 months prenatal. The crown completes at 6 months. It erupts around 16 months with root completion by 2.5 years.
Deciduous second molar development begins. Crown completion occurs at 10 to 12 months. Eruption follows between 20 and 30 months. Root completion concludes at 3 years. For the deciduous central incisor, development begins early. Initial calcification starts at 3 to 4 months. Permanent central incisors erupt between 6 and 8 years. Calcification begins at 3 to 4. Calcification begins at 7 to 5 years. Mandibular at 7 to 5 years. Root completion finishes, BEBS.
Deciduous dentition, the canine. Calcification, 4 to 5 months. Crown 6 to 7 years. Mandibular, 9 to 10 years. Root completion occurs between 12 and 15 years.
Let's review the first premolar. Calcification starts by 2 years. Crown completion occurs by 6 years. It erupts between 10 and 12 years. Roots complete by Deciduous first molar development. Crown completion occurs by 3 years. Both teeth erupt by 7 years. Roots are fully complete by 10 years.
Third molar calcification begins. The crown completes by 16 years. Eruption occurs by 21. Roots fully complete by 25.
Teeth eruption can be affected by genetic disorders. Late teething is when no teeth appear by 12 months. It is associated with low thyroid levels. Most erupt by 15 months. Your smile starts with prevention. Stronger, smarter materials are changing dentistry, restoring function and confidence. Every smile tells a story.
Did you just eat something acidic? Don't brush your teeth just yet. Acid temporarily softens your enamel. This leads to acidic softening. Brushing now accelerates tooth loss. Wait 30 to 60 minutes.
Plaque calcifies into tartar, requiring scaling. Root planing smooths the surface. Clinicians may insert doxycycline. This directly inhibits MMP's breakdown of collagen. This promotes pocket healing.
Understanding dental cleanings. Prophylaxis is preventative care for healthy gums. SRP is a therapeutic treatment for periodontitis. A healthy dental sulcus measures 1 to 3 millimeters. Pockets 4 millimeters or deeper indicate disease. Healthy gums need routine prophylaxis, while deeper pockets require scaling and root planing.
Routine prophylaxis is for healthy gums, where the crestal bone is radiographically intact. For alveolar bone loss, SRP is required to arrest the horizontal or vertical resorption.
Routine prophylaxis focuses on supragingival enamel and slightly below the gingival margin. Scaling and root planing targets subgingival root surfaces reaching the base of the pockets. Let's compare dental cleanings. Prophylaxis is preventive, while scaling and root planing is a deep cleaning. Here is the typical gingival response. Expect minimal sensitivity here. Let's understand your dental cleaning recall parameters. Routine prophylaxis is for healthy gums. SRP is a dynamic deep cleaning. Clinical recall frequency typically every 6 months.
Implants offer an effective prosthodontic replacement. Success relies on osseointegration, where bone fuses with the implant. Patients must undergo clinical screening.
Several key risk factors can compromise dental implant success. Elderly patients may have reduced bone density and blood flow. Smoking and diabetes severely impair tissue healing. For suitable candidates, implant fixtures are fabricated from highly biocompatible materials. Corrosion resistance. Zirconia is an aesthetic alternative.
Dental implants require high-precision engineering. Tolerances are held within 5 to 10 microns. Surfaces undergo subtractive modifications. This micro-roughness increases cell attachment.
To prevent contamination, final cleaning is performed in clean rooms for clinical traceability. Must align with strict quality management systems, undergoing validation to ensure reliability.
Dental caries begins when acidogenic bacteria ferment carbohydrates, dropping the pH below 5.5. Untreated, this causes pulpitis and advances to life-threatening deep neck infections.
These acids dissolve crystals, letting bacteria penetrate enamel down dentinal tubules, triggering pulpitis. Non-vital teeth carry a higher risk of fractures. This highlights the importance of early detection.
Reversible pulpitis involves dentin hypersensitivity. Increased pressure activates myelin's sharp pain with thermal or sweet stimuli. Pain resolves once stimulus is removed. The pulp heals tertiary dentin. In irreversible pulpitis, the body's defense intensifies. Pro-inflammatory affection. These cells release toxicant to destroy pathogens, but this also causes severe collateral damage to pulpal tissue. The inflammatory edema leads to a rapid increase in intrapulpal pressure. This induces local ischemia, leading to further tissue necrosis. This activates the unmyelinated Irreversible pulpitis causes severe pain. A nerve block stops pain and neuropep. Ischemia culminates in complete pulp necrochamber remains a bacterial reservoir. Bacteria escape, causing periapical abscesses.
Untreated molar infections can erode bone. They can perforate the thin plate, directly entering the submaxillary space. This can trigger Ludwig's angina, a rapidly spreading bilateral cellulitis.
Ludwig's angina is a polymicrobial infection. Streptococcus angin causes rapid progression. Klebsiella jella is isolated in over half of diabetic patients.
Edema forces the tongue back, blocking the airway. This leads to severe trismus and stridor. Awake fiber optic intubation is preferred.
Amoxicillin, for acute alveolar abscesses and dental infections. It inhibits cell wall synthesis by binding to penicillin-binding proteins.
Systemic antibiotics are used in periodontitis. Doxycycline is a primary agent for this condition. It inhibits MMPs to prevent collagen degradation. This adjunctive therapy actively helps protect the gums.
Clindamycin is a systemic antibiotic. It treats serious dental infections, especially for penicillin-allergic patients. It binds to the 50S ribomal subunit, inhibiting bacterial protein synthesis.
Let's review the drug class, systemic antibiotics. A key agent is metronidazole. Used for anaerobic dental, it disrupts DNA helical structure under anaerobic conditions, causing cell death. Drug class, systemic antibiotics. Agent, ampicillin sulbactam. It is a first-line therapy for Ludwig's angina. It works through dual cell wall inhibition and beta-lactamase blockade. Let's review this drug class. The agent is piperacillin tazobactam. It is indicated for Ludwig's angina. It provides broad-spectrum cellular inhibition.
Class, systemic antibiotics. Representative agents, cefepime and meropenem. Primary indication, deep neck infections. Mechanism, cell wall disruption.
Drug class, systemic antibiotics. Primary indication, targeted MSA coverage. Vancomycin inhibits cell wall synthesis, while linezolid stops protein translation.
Let's review dental drug classes. Systemic antibiotics acillin. Topical antiseptics like chlorhexidine disrupt bacterial cytoplasmic membranes. Finally, and ibuprofen work by non-selective COX inhibition.